from the Northeast Texas Public Health District and Judge Moran regarding the status of the COVID-19 pandemic and responsive measures intended to mitigate the spread and effects of COVID-19 within the Smith County community and East Texas region. We are privileged to have with us this morning the President and CEO of Northeast Texas Public Health District, George Roberts, and then our local health authority, Dr. Jeff Levine, who you guys have all met and heard from before. Asked them to come and give an update today. We've got the beginning of a PowerPoint, and I'll allow them to go first. And then I've also got a PowerPoint with some additional information from me that I want to present to you, really just a way to give you an update. We're going to try to do this on a periodic basis so that you as a court hear directly from them and can pose questions to them from a medical perspective so that we can have good information when making policy choices here as a body. Commissioner Phillips, would you grab the right two lights there? That's great. Mr. Roberts, the floor is yours.
Thank you. Good morning, everybody. Thank you, Judge and Commissioners. It's a privilege to be here today. So let me first start by sharing our dashboard. You see the dashboard up on the screen there. Give you an update of where we stand at this particular point. At this point, we have 1,907 confirmed cases of COVID-19 in Smith County. We have, that's an increase of 145 since last Friday. Our recovered patient count is now at 511. We've had 11 Smith County residents who have died, who have passed away from COVID-19, and there are 137 East Texas patients who are in Tyler, Texas hospitals at this point in time. So we began this journey with you on Friday, March the 13th. That was the day that we announced the first 3 cases of COVID-19 in our county. So where are we today? Well, the virus is still with us, and we must continue to take these measures in the coming days. First of all, stay home when you're sick. I can't overemphasize that. If you're sick right now, if you have any type of illness, if you think you have COVID-19, if you think you have the flu, if you think you have a sore throat, stay home when you're sick. That's the best thing we can do to try to keep people from you basically passing it on to somebody else and contaminating somebody else. Social distancing, stay 6 feet away from each other. Again, that's one of the public health ways that we can do right there. The third thing is we're all wearing a mask now when we're in public. We ask people to do that mainly to protect others from themselves. So I basically wear a mask at this particular point right now if I was going to be talking to Dr. Levine. And that's not necessarily to protect myself, it's to protect Dr. Levine from me. Fourth, wash your hands often for 20 seconds. Cover your cough or sneeze when you do that. Clean and disinfect those surfaces, and keep your hands off your face and your eyes and your mouth. So these measures are crucial to protect older adults and persons with underlying medical conditions who are at risk for a more difficult struggle with COVID-19 than our healthier population. So now we've done the basic talking points. Let me just show you some charts and graphs that my staff put together for me.
And before you get there, let's go back because I want to interrupt on this one and clarify a few things that have been questions periodically for folks that are watching and see this. We've had a lot of folks that will look at this and say, wait a minute, Kilgore's not in Smith County. How come that's on there in Gladewater? What this represents is by address. Correct. And so there are some addresses that are in Smith County that are Gladewater addresses that are outside the city of Gladewater. Same with Kilgore, that are Kilgore addresses outside. So that's how we are able to categorize it uniformly, is just by address. So you'll notice folks that look at this on a daily basis will notice there's nothing on there that says unincorporated area. Right. It's all by address. So it's not saying the 1,500 folks in Tyler are actually in the city of Tyler limits. It's people with a Tyler address.
That's correct.
And so that's one clarifying thing that I think people that are watching this come out every day need to understand. The second is on the upper right, this is a very important number that we will continue to watch and talk about today, but it says East Texas patients in Tyler hospitals. It says 137 with a star, and that star has a great note that folks need to be aware of. It says positive and suspected patients from multiple counties. And what this is trying to gauge, as we've talked about, is the capacity in the hospitals is very important to watch. And so our hospitals, our regional hospitals that take a lot of individuals from other counties, we want to be sure that we're showing that to our community, because that matters greatly to our community as to how many people are in our hospitals. But the 137 is not necessarily 137 Smith County individuals. It may be 137 individuals, some from Smith, some from Titus, some from Gregg, some from multiple counties that come to our hospitals. And that's a true statement. Is that right?
Yes, sir.
Right. So folks need to be aware of that when they watch that. And then the last thing I want to just clarify is the recovered cases. It says 511. We often get, and I know you guys get, and now's a good opportunity to clarify, questions about when and how recovered cases are determined. And right now, folks should know, we've said this a number of times, but just to reemphasize, recovered cases are not reported every day. They're calculated now at most twice a week.
Correct.
But go into that a little bit about, we have a couple different ways you guys do at NetHealth to gauge when somebody's recovered. One is a time frame.
Right.
If you don't have specific information that they've been recovered based on a test or a doctor's communication or something of that nature. So just speak a little bit to the
Sure,
recovered
sure.
case, and then we'll move on. But I wanted to be sure to point that out in particular. Go
Sure.
ahead.
So recovered patients basically it's 14 days since the onset of symptoms and 8 days since your symptoms have gone away, such as your fever, without using fever-reducing medications such as aspirin, Tylenol, et cetera. The other thing is a time-based thing. At roughly, if we've made no impact or we haven't heard from you, roughly 22 days. We know you're not in the hospital. Roughly 22 days since this process has started, we'll judge you as recovered. There have been some issues about the last few weeks as the numbers have grown dramatically. Quite frankly, my staff did not have the chance to check the recovered numbers as well as we would like to. So that number was stagnant there for a few days, and we released like 200 people as recovered last week. So hopefully, our plan is to do that twice a week, but again, knowing that as the numbers have increased, the staff has been pretty stretched. So the first step of them is to make sure we get the positive case all entered, et cetera.
That's a good point. Commissioner Hampton has a question, and then I'll have one more comment about that. But go ahead, Commissioner.
Sure.
Mr. Roberts, I have two questions actually. So a person that tests positive for COVID, but they don't go to the hospital, they just go back home. Do we still track them as well?
Yes, so if they lab tested for COVID,
And they were positive.
they're positive, yes, they would be part of the contact tracing process. So we would call them, we would call our contact tracing people, staff would call them, ask them how they're doing, check with them on who their contacts are, and then that's would be our follow-up with them is to say, and then encourage them, say, hey, we really need you to basically stay in self-isolation for 14 days from the date that you received your positive test result. So
Okay.
that's our strategy there, and that's one of the real values of the contact tracing format is basically to have that touch point with somebody to basically encourage them to stay home. Because again, the way we spread this, my first talking point was to stay home when you're sick. The way we spread this is that if we're out in the community, if we're still shedding virus, you can infect somebody else. So the best way to not infect somebody else is for you as an individual, if you had this, to stay home.
And the reason I was curious because I know someone that just had a sore throat and a fever, went in, tested positive for COVID-19. They sent them back home and told them to quarantine for 14 days. So I was just trying to make sure that we were
Right.
keeping contact on those people.
Yes, we do make contact with them, and sometimes that's been one of the issues as we've gone along in this process. The lab testing, us getting the result is, sometimes it could be 5 days to 7 days to get a positive result. By then, the patient could be recovering. So it's very important for that provider to have made that initial thing to please stay in self-isolation for 14 days, or for the individual to know that. But that's part of our contact tracing piece too, is to reinforce that messaging. That make sense?
Other questions for Mr. Roberts on this slide?
I have a question, or can you dispel a myth or a rumor that people who've been in these testing lines, the lines are long, they left and went home. They get a call and say they've tested positive. They didn't even test. Have you heard that?
Yeah, we've heard that, Commissioner. We have heard that several times. We tried to put that. We heard that rumor through our Joint Information Center that Ms. Murphy is part of. We reached out to the community and say, please, if that happened to you, please let us know. Give us names and numbers. We want to verify that. And we've heard nothing, because the way the system has worked on that, you had to basically walk up to the testing site. Right before you went in to be tested is when you gave them your information. So if you're standing in line outside, your information has not been given to, is what, I haven't been personally to the TDM site to see that, but that's been told to me. And when we checked with TDM, you don't give them your information until you are almost about ready to be tested. And then plus, in one of the sites, the one at when we had almost 200 people tested positive at the St. Peter's Catholic Church, we actually, my organization had to call everybody who was positive because the state basically, they were overwhelmed with numbers at that point. So my staff called everybody who was positive and let them know about that.
And Mr. Roberts, I can answer that also, because I was tested at St. Peter's, and what you do is you stand in line, and like you said, you go to the table, you fill out your information on your phone. When you get to the door to go into the clinic to be tested, they look at your code, they give you a code, they scan that code, they take all your information, go in, be tested, and then they notify you of your results.
Thank you for clarifying. Yeah, that's the way I thought it worked, but thank you for clarifying that. From personal
Yeah,
experience.
and I'll add to this also, we tracked down ourselves, in addition to you guys, I know the city of Tyler was doing that as well, the rumors of those people that had posted that on Facebook and actually had made contact with originators of those posts, and nobody could provide us an actual name. So if it happened, we really want to know, we genuinely want to know about it. We do, I know you guys do, so we can get it to the state. It's a state-run testing site. But so far, we've never been able to track down any original source, and most of the stories don't match up with the process that actually goes on out there. And some of the posts were identical posts that were cut and copied from Dallas, Austin, Houston as well. So it's unfortunate that misinformation is going on out there, but we still want to be vigilant and say, if something is going on like that and it happened to you, we want to know about it because we want to get it fixed at the state level where they're doing the testing.
Correct. Yeah. Correct. So please, if you know of anybody, please let myself know. Let one of the your peers know. Let Casey Murphy know. Let somebody know, and we'll follow up on that. Yes, sir.
George, I get calls. I know everyone does about the length of test turnaround. I've heard that people are in some hospital settings outside of our county. Some were actually out of our county, and they got the test back within minutes, really like 15 to 45 minutes. And then some are taking a week or longer. Are there that many different tests, and why would the procedure be so different?
Yeah, no, our information from the hospitals is. Let me look at my notes here.
Again, because we're hearing so much that is not factual. I really want to hear it from the
the hospitals are telling us that they typically. For their turnaround times for their labs are typically 24 to 48 hours for their hospitalized patients and 48 to 72 hours for their outpatients.
So I've not personally had anybody kind of like the other deal that really could say, now who was this that got a 45-minute test and they knew it? Do you know of anything like that?
I think Dr. Levine.
Okay, he may address that in a minute. I just want to bring that up in a little
question for you
as
well. There are places to get that. Sometimes they're rapid tests. Sometimes they're what's called an antigen test, and we have found so far on this is a little inside baseball here, but we only count what's called the PCR tests on our positive count. Antigen tests have not been found to be quite as reliable as the PCR tests. So at this particular point in time, we have not been counting those antigen tests in our count.
Sometimes those are
the faster tests.
A personal friend that has 4 people in their family, 3 of them are sick, one's not. They went and had the test done, is back rapidly. The only one that tested positive was the one that's showing no symptoms completely well. The other 3 are sick. Now, they may not have COVID-19, but it's ironic that she pasted fine. She's fine. But the 3 of them are the ones that are sick and they passed negative. So it does throw into doubt some of the results that are coming out.
Right. And the asymptomatic spread, that's one of the things that we've talked about with, the reason why our talking point is, stay home when you're sick. Okay, if you're asymptomatic, you don't think you're sick. So, but then why do we stay 6 feet away from each other? Because I may have this right now. So I don't want to give it to you. I don't want to give it to Dr. Levine. That's why I wear a mask when I can't be within 6 feet. When I'm less than 6 feet from somebody, I need to have a mask on. So that somehow is catching those respiratory droplets, which is how COVID-19 is spread. It's spread through those respiratory droplets coming out like that.
Thank you.
Any other questions or comments about this slide? If not,
I'd just like for you to, I'd like to see the numbers of the people that's tested, how many is negative. I mean, we're always hearing the positive cases. When you test, how many is negative?
So right now there's about the data, the judge and I were talking beforehand, he shows, I looked at our numbers, we're around 15%. Our overall, if you look at the DSHS website, there's been roughly almost 13,000 tests that have been conducted, and you see 1,900 people have tested positive, so that's roughly a 15% positivity rate. The hospitals will tell you if somebody that goes into both hospitals said this the other day on a call, that for somebody that goes into their hospital or their clinic that has symptoms, and we'll go through those symptoms here in a few minutes, if you're symptomatic, 30% of those people are turning around positive. So if you basically walk up to a testing site, it seemed like it was 10 to 15% positive at the testing site, because a lot of those people going there at the free testing sites were asymptomatic. But if you walk into a clinical setting and have some type of symptoms, 30% of those are coming back positive.
Yep, and I'll show some statistics from our most recent testing sites here in a bit. So about 85% of those folks tested negative and about 15% tested positive. On this, the last thing I'll point out, again, is that 137 number on the upper right of our daily dashboard. If you all recall, back in April, May, early June time period, we were running somewhere between 45 and 55 on that number. It really vacillated between 45 and 55, sometimes got lower, never much higher than 55. And then in late June, it began to make a pretty good quick rise to 75, where it was for a little bit. And now you've seen another quick rise. This is the really important number that I want to emphasize to you and to the community to say, let's watch that hospital capacity, because by percentage then, even though we're not talking specifically about how many are in ICUs and how many have ventilators, by percent, you know that those numbers are going up as well with the number of patients in the hospital. So that's a critical number, and a number that we are continuing to talk to the hospitals about right now. That's still manageable, but watch that number, and as it increases, that's the number that really, I think, is going to drive a lot of concern for how we are able to treat people in the long term. That number can't get too high. Do you disagree with that?
I agree.
All right. I just want to be sure that we're seeing that trend, because that trend's going up, and that's an important trend to watch and be cognizant of.
And you remember when we first started this thing, we remember talking about flattening the curve? Remember that whole flattening the curve?
15 days to flatten the curve.
To flatten the curve, basically, it was all about, we were trying to keep the hospitals at a reasonable capacity so they could handle the potential load that we really were concerned, particularly in April, was going to surge. The other issue about it flattening the curve was, if you recall, personal protective equipment. If you remember, in March, we were basically, all of us were pretty concerned, might be an understatement, about personal protective equipment. And through basically the supply chain really started, I think probably late April, early May is when the supply chain really started coming up, and Iraq has done they basically had nothing, basically had very little to pass out early on. But their supply chains have increased dramatically, and at this particular point in time, there's a good supply of PPE for the hospitals, for the first responders, for the nursing homes, for public health. So right now, we are in good stead with our PPE, but again, that's something we pay attention to. That's on that we get that information from the hospitals daily as well.
All right. I think we wore you out on that slide there,
That's
Mr.
okay.
Roberts.
That's okay. That's why we're here. So
Go ahead.
There we go. So this is what so I've got, like, I think 13 or 14 different little graphs here I'm going to show you here. I'm going to start off with and Casey, I think is there a little red dot on here?
Need a pointer?
Yeah, pointer.
Oh, that was good.
So this is the rate, this is the COVID-19 case rate by zip code. And basically our rate, I think the judge is doing it per 1,000 population. Our numbers are I'm going to show you per 10,000. So when you see, I saw the judge's, some of his notes a little while ago, he's looking at per 1,000, I'm looking at per 10,000. So if you see here, the higher rates are in the, so we're not just looking at numbers of cases here, we're looking at the rate of population cases per 10,000 here. So if you notice here, then the 75702, can't see where, there it is, 75702, 06, 08, and 09 zip codes. Those seem to be our highest concentration of the, again, cases, not numbers, but cases per 10,000 here. And so you'll see a lot of other counties here. That's because, I think we've talked in here before, NetHealth, we do public health emergency preparedness and disease surveillance in 7 East Texas counties. So you can kind of see down here in Anderson County, Henderson County, over in Gregg County over here, see the higher numbers over here. But again, focusing on Smith County, you can kind of see the idea. So we're watching that information there as well. Next slide. is going to be our NetHealth COVID-19 daily new cases. And this is when the information is reported to us. I'm going to show you a slide later on is when the data of the lab test drawing, which is our mitigation chart. But you kind of see here, this graph here kind of tells a lot of the story right here. We were trekking along pretty, kind of a nice little flat line here, and all of a sudden, about the 20th or so of June, it really starts growing up. That was one day there. That was the big day when we had 250 cases that came in. A lot of that had to do with the TDM testing sites. There were 189, I think, Smith County residents just from the St. Peter's Catholic Church. I think they did testing on like 1,700 patients over a 3-day period. But then there were several other test sites that week as well. And you see, so it's a high point right there, but that was a lot of the TDM. And a lot of the TDM testing has really taken our numbers up. And we're good. We want to know that information because, again, if you're asymptomatic and out in the community, you're spreading the virus. So we want you to know that information, so therefore you will stay home for 14 days, get over it, and not spread the virus anymore. This is the crude attack rate by county. I know that the judge has this in part of his presentation as well, but just to show you here, Anderson County, again, this is per 10,000, so right at 57 in Anderson County, 86 in Gray County, right around 50 in Henderson County, right about 20 in Rains County. We're at 76.65. And again, this number will kind of ebb up. This is as of Friday, this past Friday. That number will kind of change a little bit based on what your numerator. I think I used Smith County population of 232,000. I think you used, 235? So you change that around. But again, it's going to be pretty darn close to the same thing. Then Van Zandt and Wood County there.
So define for us what a crude attack rate is.
Basically, it's the number of positive cases per 10,000 population in this particular situation. So I'll just give you some other information here. So in comparison, Denton County, I looked at Denton County. So we're at 76.65 here in Smith County. Denton County is 55.08. Harris County, 116.29. McLennan County, which they were really tracking right along beside us for a long time, and then all of a sudden they've spiked here in the last couple of weeks too. They're at 128.24 right now. In Dallas County, it was just under 170, 169.85. This is the NetHealth, the COVID-19 combined racial ethnic distribution, and you see, you'll see some numbers here. Let me just tell you a little bit about this. So, a lot of times we don't get the racial ethnic. The hospitals typically are pretty good about that, but we have some clinics that don't give us that information. The TDM sites basically gave us, we got name, phone number, positive or negative. So a lot of this, so quite frankly, so this is but it gives you a sense in our 7-county area what the percentages are. And the positive cases, according to our data, 52.5% white, 22.2% Hispanic, just under 1% Pacific Islander, African American, 24 point, is that 9? I can't see over there. And then Asian is a very small percentage there. But essentially, I think that's kind of how things are breaking out racial ethnically there.
So can I ask another question? Are we doing something, and I know the Hispanic population is at 22.2 and the African American is at 24.1. Are we doing something to target our Hispanic population to let them know that those numbers are going up? Are we putting stuff out? And I know we're putting stuff out in Spanish.
Yeah.
Like we did a commercial just for the African American community, the elected officials. Can we do something like that for the Hispanic community?
Yeah, I think we've done some, Casey, we did some, help me on this one. I think we did some, actually Dr. Levine the other day, who actually he kind of kept this a little unknown secret, but he's actually was a Spanish major, so he actually recorded a message in Spanish the other day.
And maybe we can get someone from the community to
Yeah,
also,
we've done.
I mean, Dr. Levine is from the community, but someone that they can identify with all the time.
Yes, I think that's. I know Yvette Zavarse did something. I think Nancy Rangel.
Yeah, I
did
was
something.
like Nancy Rangel, make sure she.
Yeah, I think we've done some, but I think that's a good point. We need to keep doing that. And as when I talk about contact tracing, that's been one of our gaps in our contact tracing is we've had getting the Hispanic community. So we've really tried to be very. We've reached out. I think we're going to bring on some more Spanish-speaking contact tracers here very quickly as well. We're trying to find some people right now, but I've taken some of my own staff that are doing some other things and have pulled them in to try to help with the Spanish contact tracing as well.
Thanks.
This is Net Health, our whole area. It's basically, this is kind of a lot of information on this slide here, but basically it's male and female, whether they obtained the virus by travel or community. And, early on, we were very interested in the travel piece of this thing because, initially it was travelers bringing it in our community, and then it became community spread. So what do you notice on this slide is that where's our largest cohort here? 21 to 30. 21 to 30 right here. And for a long time, too, it's interesting that it seemed like there was more males than females with COVID, and now it's kind of starting to change. It seems like it's more females than males now, as you can kind of tell on this line here. As you go up the graph here a bit more. But it seemed like our biggest concentration is really in the 30 to 60 crowd seems to be the biggest concentration here. Again, the travel is not as specific there. And I'm going to show you one, Smith County. Look at that 21 to 30. You kind of see that, how much, it's even a wider gap here in that 21 to 30 crowd. And then again, it looks like the 11 to 20 and these other groups are staying around the same, but this seems to be in this graph here in Smith County, 11 to 60 seems to be our primary people. And again, we look at that because, who's most vulnerable here, where we said basically it's people who are older, 65 plus, but it's also people who are medically infirmed, have comorbidities. And in talking to the hospitals, I talked to a physician. I said, what are you seeing over there right now? And he basically said, typically it's people, he said, I'm not really seeing anybody under the age of 50, and a lot of the times they're obese. And so obesity relates to cancer, heart disease, hypertension, diabetes, lots of things like that. But comorbidities seem to be such a huge piece of this. It's typically somebody who is healthy, is typically gets through this. If they hit COVID, they typically get there pretty well. The people who had the most difficulty of that were people that have other issues going on medically. You can kind of almost compare. People get the flu. People will die from the flu, but a lot of times it's the people who have other things going on besides just the flu. Here's another just basic kind of age distribution there. Again, showing it the whole, just pure numbers here. Again, this is our 7-county area. Again, look at that 820 and that 21 to 30 crowd. This is an interesting slide here too. I have this broken down. I'll show you first just the whole area. This is for the, move on my notes here, make sure I'm telling you the right slide here. Our 7-county jurisdiction here, this is approximate school grade level. If you look over here, and I'm going to move this way. Whoops. So, look at this again, our whole area, 19 pre-K 3 to 4, 102 K to 5, 6th to 8th graders, 71. And as the kids get a little bit older, it seemed like, particularly the college age group. So it's interesting it seemed like the numbers here are relatively low. And then we'll look at just Smith County. Same chart, but look at the number again. Pre-K, 57, 33, or 137 in this age group, and then 240, 239, 240 in that group. Here's our mitigation chart, and this is a chart. I know it's a favor to Dr. Levine's. I usually get him up here to explain this thing a little better than I do, but I guess the main point of this thing is, look, this is the whole flattening the curve. So this is looking at, this is the whole thing of, and we look at this, the date right here that you see, any date that you see is the date that the test was drawn, the lab test was drawn. So they've showed up, that probably big one right there is going to be around the St. Peter's Catholic Church and some other things right in there. But again, the date that the positive lab test was drawn versus the date that we get reported. But you look at the numbers here, and we put the little dots, see those little dots there? Those dots, go back to such things as, okay, that was first case there. You get into where the judge issued his order, stay-at-home order. You get into here, this is when the bars open in Texas. This is when the bars closed. And then you see, that's July 4th right there. So we have a number of dates on that. If you put a copy of that, we can certainly get that for you. I think that's a very interesting chart. Again, that's the whole thing about us trying to flatten the curve. But what you see right now, where the curve is going up.
And we're going to post that. I'm glad you mentioned that. All the commissioners have a copy of that, but we're going to post this on our coronavirus page on our county website. So anybody that wants to watch this video after today can refer back to these PowerPoint presentations to see exactly what we're talking about. We're also going to post them on Facebook along with a video of this presentation as an update so folks can see that independent of the Commissioners Court typical video, which is a lot longer. We're going to clip this so that people can just get this update.
Okay, thank you, Judge. Appreciate that. The last three slides I'm going to show you are deal with deaths. This is just, so this is our seven county area here. You'll see here that the 31 of the deaths are the race is white, 3 Hispanic, 7 black. That's, again, the whole 7-county area jurisdiction we have. And then here's just Smith County proper. 7 white, 1 Hispanic, 2 African American. We did have a death yesterday. It's not reflected here, and I'm not sure wasn't given that the race on that, but that gives you a sense of where we are, deaths by race here locally. And then this was my final chart is basically the age of people that passed away. We said there's 41 deaths, and you'll see like 25 or 26 data points here. That's the reason why that is that there's several people like that. I know 74 years old. There's several people that had the same age on here, so they're kind of combined. But you kind of see the youngest person that has passed away was in one of our other counties was 47. I think the oldest person has been 95. But you kind of see a track. Again, it's not the graph here is just to show the age of the people that have passed away due to this COVID-19. I'm going to move off of the graphs now and just talk to you about a couple other things and answer any questions. And again, Dr. Levine is here as well. Contact tracing, we mentioned a little bit about that. We have roughly 30 people that are helping us do contact tracing right now. This includes roughly 16 of our own staff members, plus a number of individuals outside of Net Health. And I want to thank the Commissioners Court, for helping us when we very early on, you gave us the use of some people in the DA's office and the Sheriff's office to help with contact tracing. We basically told them they could go back to their normal duties in June. And then when the spike happened, I called the judge and I called Ed Broussard at the city and said, I need some help again. So we appreciate the folks in the DA's office and the Sheriff's office, again, helping us with that. The City of Tyler's also helped us. We've also reached out to Smith County Medical Alliance. My own board chair, Dr. Mitchell, is helping do contact tracing now. Gray County Sheriff's Department is helping. UT School of Pharmacy has helped us big time. We've reached out to the School of Nursing to help us. So we've got a lot of people helping us do the contact tracing right now. Again, that's why are we doing the contact tracing? It's an essential piece to get people to, when Commissioner Hampton and I were visiting Q&A just a minute ago, it's just an essential piece to try to have that touch point with somebody to say, hey, you had this, let's talk about this, get their contacts. So again, we can encourage them to self-isolate for those 14 days, find out who their contacts are so they can encourage the same process with them as well. Testing. Local providers have access to testing, but they require that you have symptoms. And we've used and the symptoms basically are, again, the symptoms have changed. If you remember early on, we were saying fever, cough, and shortness of breath. I could spit that out at a moment's notice. But now it's fever or chills, cough, shortness of breath, difficulty breathing, fatigue, muscle or body aches, headache, newly acquired loss to taste or smell. When I hear somebody calls me and says, I've lost my taste or smell, I'm like, uh-oh, that's become a telltale sign there. Loss of appetite, sore throat, nasal congestion, runny nose, diarrhea, vomiting, nausea. And so, again, the Texas Department of Emergency Management has conducted a lot of these free test sites. There's not one, Judge and Commissioners, that I'm aware of this week. I'm hoping next week there will be. I know last week, again, in White House, they had, just in one day's time, I think they saw over 800 people at that one testing site in White House. So that was pretty great there. So, again, we mentioned the testing. I told you the exact number on the DSHS website. There's been, according to DSHS, there's been 12,968 tests performed on Smith County residents since the start of this thing. And in Texas, just under 3,300,000 tests have been performed. Hospital update. Again, we've been in constant communication with the hospitals. We received their dashboard, which I know the judge is going to talk a little bit more about, but that tells us positive and suspect COVID-19 patients. They're available ICU and hospital beds, ventilators, big piece of this. We want to know what's their ventilator capacity, isolation rooms, and again, the status of their PPE, personal protective equipment. At this moment, we typically meet in our EOC, and we've asked the hospitals to call in to us and give us a report and an update because we want to know. We want them to be honest with us. But last week when we met with them on Thursday and talked to them, they felt good about where they stood at that moment in time. And again, well, use the word moment in time. Right now, they feel good about that. But again, the numbers are going up. But again, 30% positivity rate for the people they test in their outpatient clinics and inpatient clinics, inpatient staff. Again, 15% overall. And again, our positivity rate has been going up. We were, back in April, May, I think we were around 5 or 6% on that. So finally, school update. The TEA is recommending that schools come back in session in August. Our Smith County ISDs are having discussions right now, and they've asked us, I'm going to be on a call with them later on this afternoon to give them advice and work with them how best to do this. That's a big issue around the state is when is it safe to go back to school? How do you go back to school? So I know the ISDs are working on that right now as we speak, and there's people like the state's working on that. So we'll be having conversation with them, trying to give them the best counsel that we can about that as well. Finally, special shout out to my staff at NetHealth. My staff is, a lot of people went to work from home. My staff did not work from home. They continue not only with preparedness and disease surveillance, working on this pandemic. My PIO was there every day. Our community outreach staff were there every day. WIC, several of my peers around the state actually shut down their WIC clinics. Northeast Texas Public Health District, WIC, in our service area of 20 counties, we were there. Now, our service model is different. Our clients aren't necessarily going to our WIC clinics. We've been doing, coming out to their cars, servicing that way. We're still servicing our WIC clients. Our environmental health staff has still been working. Our lab has been working. TB control, immunizations, vital stats, and our Center for Healthy Living have all been working hard. And thanks also go to the Smith County for Judge Moran. Judge Moran has spent, I'm sure you're aware of this, but I can tell you because I spent a lot of time with him over the last 4 months. We've all put a lot of time and energy in this effort, and I know you guys have received a lot of phone calls yourself, but I appreciate all your efforts and your questions that we've gone through this. City of Tyler has been a great partner in this project as well, and it's really a neat deal because this, for the first time in many years, as long as I've been around, this is the first time that Smith County and City of Tyler had a joint EOC, and I really can't, Judge and Commissioners, figure out how we might have handled this if we'd had two different EOCs going. So, I mean, the fact we were all in the same room talking was very great. So thank you all for that. And finally, thanks to our health authority. Dr. Jeff Levine has put many hours of service into this whole thing, as you're well aware. And, he has other duties at UT Health Science Center, but he is basically, this has been his life for really the last, since first part of March. I know when I call him a lot of times, I've talked to him at 8 o'clock at night, and he's still at the office. So Jeff has put a lot of time and energy in this, so we're very grateful for him. So with that, we're here. I'm here for questions, and Dr. Levine is here for questions as well, and Judge, you're here for questions. I don't know if you want to do the Q&A now or if you want to go ahead and start with
let's go ahead and get some questions for Mr. Roberts. And then Dr. Levine, did you have anything specific you want to present or just answer questions?
Just answering questions.
All right, so let's begin the Q&A time for both of these gentlemen, and with thanks for their time commitment today. Any questions?
Judge, I have a question. Judge, first of all, great presentation. Thank you so much.
Thank you.
But you did not touch on daycare centers. Is there any special information you can give for daycare centers?
That's a good question. I can look on that. We can add that to our presentation next time.
Would you?
Thank
I
you,
serve on a board of a daycare center, and I know we worry about our kids, especially our babies coming in there. But so far, we haven't had any problems. I just wanted to make sure that the community are aware of what's happening with daycare centers.
Yeah, they've worked along pretty well. I know we had discussions early on with them about how do you, maybe do the hospitals set up their own daycare center? How do they handle this? And, my philosophy on that was, it's like, hospital's going to set up a daycare center. Let the daycare center people, let's help them be successful versus setting up separate daycare centers. So that was my philosophy. But I'm glad that you're the one that you worked with has done well.
Oh, we've done great. We did it for the essential workers when everybody shut down and we could only do essential workers, and we were able to do that. We closed down on every Friday and did a deep cleaning. So, yeah, we've been working right along.
Excellent. Excellent.
That's all I have to.
That reminds me to mention that we're still doing good on our nursing homes. For anybody that's curious about that and tracking that, we're doing good on our nursing homes, and also we're doing really well currently at our jail. That that issue resolved itself through good management, and that's not a problem right now going on. I know we had a number of folks at one point a couple months ago in the jail with it, but we're not dealing with that anymore.
That's a blessing. Jail, I'm glad that's resolved. The nursing homes, we were very. Again, go back to the whole model. We heard already on, basically our biggest concern is going to be the nursing homes. And anytime we've had either a positive patient, in particular, or primarily positive staff member, we have, I personally have talked to a lot of nursing home administrators, and basically we tried to, help them anyway. Our job was not to put them under our thumb, but basically to offer help and assistance and encouragement, make sure they had PPE and a listening ear to help how they might do things. And so far we've been very, very fortunate with that.
Other questions for Dr. Levine or George Roberts?
What would be interesting to find out, I think, to know is the age of the folks that are in the hospital, those 137 people, at what age, because your graph showed there at one point the biggest growth in this positive testing was up to age 30, I believe.
21 to 30.
21 to 30, and even up to maybe some up to 50, but and in those graphs that are really growing, from the teen, you said the college, that was, and you showed the school age and all that. So it shows that the positive rate are those that are out, getting out, moving around, socializing, doing things, but it would be nice to know how much of those are tying up our hospital space or whatever, because it seems to me that those aren't being really affected as, the older ages.
Yeah, anecdotally, like I said, the physician I talked to a week or so ago basically said, when I asked him the question about what are you seeing in the hospital, and this gentleman's a radiologist, and he said, I'm not seeing anybody under 50. That's, and is there a one-off that's in there under 50? Well, perhaps, but typically it's somebody, typically older, 50 and older.
And that's kind of what I'm getting at, and I'm glad to see you say that. But I think we're just lumping everybody in this whole COVID thing when we ought to be really focused in on that 50 and up, and those that are, like you said, obese or older or whatever, and really have them watch it with their mask and stuff, and relax some of this stuff on some of these younger ones, like going back to school and some of those things. That's just my point of view. But
well, I think one of the things too with everybody, I think that one of the the aha moments for me has been, we've worked a lot with Fit City for the last 10 years, and what can we do to encourage our local citizens to basically stay healthy? Again, we need to really consider if health issues by what we eat and our eating and exercising patterns, if we can encourage everybody to get back and exercise more, watch what you eat, and basically, the idea that's going to help if we do get COVID, we all, the virus we all can get it. The question is, how are we going to handle it when we get it? And it's incumbent on myself. I have to look myself in the mirror and say, okay, what are you doing to stay healthy? And I try to watch my diet. I also try to maintain a good exercise program, at least walking, a good walking habit. Try to get 10,000 steps a day, but try to do some weight training and things like that. So basically, encourage everybody to basically try to get healthier. And if we can get healthier, I think we can address basically when we get COVID, or if and when we get COVID, we can handle it better than if we're unhealthy when we get it.
Commissioner Phillips is making a good point here, because when we saw the graphs and the number of individuals that were getting it from 21 to 30, I think we can fairly conclude from that because the numbers are lower when you get above 60, 70, 80 range as to how many people actually have it, that a lot of that is a result of choices and behavior of those age groups. Mm-hmm. And that the older age groups from very early on, realizing that they were more vulnerable to the effects of COVID-19, were making more safe choices and better choices to socially distance, to wear their masks, to stay out of large crowds, to not be in a place where they're likely to contract the virus, whereas individuals that are younger are more likely to be social, get out, and do those things that cause the contracting of that virus or the spread of that virus. So it really underscores what we've been saying from the beginning. Personal choices and behaviors matter when it relates to community spread. Those are in that vulnerable population, that 50 and above, are making better choices probably than those that are in that younger age group. And so that should be instructive to us about if we really want to curtail the spread, how should we behave, like a 21-year-old or like a 60-year-old? And I think probably that choice is to follow the example of our older population that are doing a better job staying socially distanced and doing the things that they need to do to not contract that virus. Would you agree with that?
Agree.
Okay.
That'd be a good advice on just about everything in life,
Yeah.
I think. But anyway, I do have a question for Dr. Levine, or a couple of them if we've got a moment.
Yes, we've got, go ahead.
Okay. Dr. Levine, thank you so much for your diligence in your work. And as you can only imagine, being in the low elected position we are, we get a myriad of emails, YouTube things, conspiracy theorists. You know, there's such a distrust of government. And now, unfortunately, medical decisions have also been merged with governmental decisions, and something where people used to just take at face value. You know, this physician recommending that is now being met with a lot of doubt. We're getting that, you know, pushed back on us. But I just want to ask a few questions on the macro. You know, I understand we're not the dog. You know, we're at the tail end of being wagged, but you know more in tune of what's going on. If the governor does an order, for instance, we've all seen Dr. Fauci say masks are not valuable. I mean, we watched that with our own eyes. Would do no good for him to wear it. You can see it on YouTube a million times. People have sent it to me a half dozen times. And then within 6 weeks, now I understand things change, and it's probably is a good idea, and so that's the reason I have mine here. Go out in public, I'm going to wear it. But there's so many conspiracy theories when you see things like Japan having a very small death rate, 1,000, 1,500 people. I didn't believe that, so I verified some of those. Taiwan has less than our East Texas region. It's hard for us to calculate there when we have the finest healthcare system in the world. What are they doing different? And I just want to see if you have any insight. Are we trying all those, steroid treatments and things early on to see if people never get hospitalized?
That is a macro question. It's a big question. I want to just start, by thanking you all for grappling with these macro major questions. We should not assume that at the start of this we knew all the answers. And I think there are recommendations earlier based upon whatever things we did know, that as time has gone on, we've had to look at those differently.
Excuse me, Dr. Levine, we can't hear you.
Oh, I'm sorry.
Let's get a little closer.
If you just get a little
We've had
closer.
to look at those things differently. And, I was reflecting as George was giving his presentation here, how much data we've thrown at you this morning. It's mind-boggling, and it's easy, not for you, but anyone to look at all this data and to consider it as being there to confuse, that people can't trust it. There's so many different numbers. What's the right number? The data is there to inform, and we should, I think, look at the data not with what our agenda is in mind, but don't try to read any more into the data than is there. But we can't just look at one piece of data to try to get at the right answer. I would comment on, what you were saying about other countries and our healthcare system. I think you're right. We have one of the best medical care delivery systems in the world. I can't say that I would agree that we have one of the best public health systems in the world. Consider this a personal opinion, but I think we have dramatically under-resourced our public health system. I think we are catching up with archaic systems to collect this data and information while being mindful of people's personal information and protecting that information. But the way we go about this, we're using old technology, old data systems. We can't get real-time information to feed up through a single common public health system where we can make decisions on a daily basis. And that is not something, in my humble opinion, that you can just turn around at night or by even throwing a lot of money at it. It takes time to build that kind of system, and I don't think in that regard, in this country on a macro level or on a small level, that we were really prepared for that, because we almost thought that this would never be an eventuality. To the medical treatment piece, I know that there have been some questions. There are lots of possibilities out there. People are, promoting, George and I were talking about this issue of inhaled steroids, budesonide. There are some physicians, anecdotally, who have great experience with this. We heard anecdotally on a macro level that hydroxychloroquine seemed to work. I don't think for us in the scientific realm that we have that we're there saying it doesn't work because we have some agenda in mind. We are very faithful to the notion of using evidence and making evidence-based decisions. Though something may work anecdotally, it is incumbent upon us. We would violate your trust if we just went out there and said, well, that works in that case, let's try it in everyone, right? Some things are dangerous and some things don't work. And it becomes almost charlatan for us to begin to say, well, because it worked for him, it's going to work for everyone else. All I would say is for things like that, we have to continue to study those things and to try to get the best answers in order to recommend them. But right now, they don't seem, the inhaled steroids, for instance, don't seem to be particularly harmful by comparison to injected steroids, which early on in the case of COVID, there seemed to be some concerns about using treatment with injected steroids. So I don't know that I've done a very good job of answering your question at a macro level, but I think there have been some challenges, and to dispel myths or conspiracy theories, I would not be here presenting you with information because I have any particular opinion. Everybody's entitled to their opinion about a theory, but in the end, we should look at all the data as well as we can and understand the limits of it and interpret it in the best way possible without thinking that every piece of data has an agenda tied to it.
I agree. And I'm just hoping that, that the trust that government is critical for us, and we're at the lower end all the way up, for people to think that both sides, all political parties, whatever, are looking for a real solution and not looking to exacerbate the problem. And, I'm just thinking if whatever they're doing in these other countries, because they obviously are mass populations in very enclosed area, and some countries have done nothing other than particular treatments. If they're really having a lower death rate, I would assume that somebody in Washington can get on a plane and just fly over there. Yeah. If they don't want, I hate to be just simple, but I'm a simple person from real deep East Texas, that I'm thinking if those, I don't know why their numbers are lower, but I'm hoping that powers way above us, and you would know more about that at the CDC or whatever, aren't looking at us to we don't have to cure it here in Tyler if we can treat it. And there's a simple way to treat it to buy some more time. That's my only concern, because I get that. I don't know if y'all do or not, but I'm getting these emails
I
periodically.
do. If we can treat it, I think that you're right about that. But in general, and I know that in a perfect world we can say this, any death is an unacceptable death, right? And so the only way to keep deaths from happening, despite whatever dramatic treatments we're going to have, is to stop the spread of the virus. And though we should continue to try to treat people the best possible way, to make every medical resource available to them, and to lower the number of deaths, we need to back up, again, my opinion, and get rid of the spread of the virus, right? And so these population health measures, masks notwithstanding, or 21-year-olds versus a 60-year-old, right, staying at home or wearing a mask. We cannot do that with just certain groups doing it. We have to do it as a community to outsmart the virus. Just like herd immunity, it's like herd masking. If we want to stop the spread of the virus, the people that the virus is agnostic to who it infects. All they're searching for is a human being to infect. And if you're symptomatic or asymptomatic, it, again, is irrelevant to the virus. So the only way to keep it from spreading from one person to another, even in that big population who are asymptomatic, is for them to participate in not spreading either by social distancing or masking. Again, and I think there is pretty good data, and I can cite the data and evidence for that.
Right, thank you.
I have one question for you, Doctor, and it was brought up in the comment section early on about the oxygen level of the mask and OSHA and all that. Is there any truth to that, and is there any health concerns for people with reduced oxygen or whatever by wearing the mask?
That's another big question. So I think there are points that I would agree on, and I'll completely stay out of the realm of legal principles and all of those sorts of things. I am not in agreement that there is good, solid evidence about the reduction, the significant reduction of oxygen levels to the wear of a mask or respirator. I can tell you, I have spent my entire career in occupational medicine dealing with issues of respirators, clearing people for safe respirator use in work environments, and that sort of thing. And there are some reasons that some individuals should be much more cautious about the ability to wear a respirator. But in terms of the actual cited evidence, there may be certain kinds of devices that would do that, but broadly speaking, that a mask reduces oxygenation of the blood by that amount, I would have to look at the evidence for that because I have not seen that evidence.
Other questions for Dr. Levine or George Roberts? I cannot tell you how much I appreciate your attendance here today and the information you presented, because it is always helpful. As Commissioner Moore said, we get a number of questions and we're barraged with a number of different rumors or innuendo, and it's nice to get the straight scoop from each one of you, and we appreciate getting the straight scoop from you, because I know that what you have at the forefront of your mind always is the best interest of the public health of Smith County, and that's genuinely nice to get that information so that we as policymakers can take that information and make hopefully good policy choices going forward. So thank you both. I'm going to provide just a little bit of supplemental briefing. There were some things that I wanted to touch on just briefly as a member of the court, to give this court some additional information on some of the recent testing. This will not be long because I know you all were really interested in what they had to say, but I want to give you additional information also about some testing recently, and leave you with this as well. So we had a couple of recent drive-up and walk-through testings for Troop, Lindale, and White House. White House, on that last bullet point, had 887 tests conducted on July 16th. Those results are not back yet. Hoping to get those results quickly, and I'll come back to that here in a minute. But I wanted to break down for you the total from Troop and Lindale, and then underscore some conclusions from that. So we had a total of 274 in Troop that were tested, and 39 were positive, 235 were negative. The percent positive there was 14.2%. In Lindale, very similar, 382 tested in one day, 48 were positive, 334 were negative, 12.6 of those were positive. As Mr. Roberts said earlier, and it is correct, previously in April and May and June, we were seeing about a 5 to 6 to 7% at the highest positivity rate of those that were tested. So you see there's a much higher positivity rate now, and back then, as you recall, we were testing only people that were symptomatic. A number of these people, this is one of the things I want to say about this, a number of these people are asymptomatic. So think about the testing itself. These are not individuals that show up to the hospital or the ER or their clinic or their doctor because they're really sick to get tests. Most of these individuals, talking to the people that were on site there, showed no or little symptoms themselves. And in fact, Gene Cottle from Troop gave me a great report of their testing down there, and he was down there for most of the time frame. And he talked to the police officer who was there for the whole time frame. He said, "I can tell you, people that were in line just didn't look sick and didn't appear to have the virus." And this is important because this underscores to us that you do not know if you are carrying the virus or if somebody else is carrying the virus based on just outward symptoms. You have to assume that you may have it, and you have to assume that somebody else may have it, and you need to conduct yourselves in that manner, in my opinion. The total test results on the White House one, if that proves true, if we use the 13.2%, that's about 117. So let's wait and see. Let's see statistically what turns out from the testing site from White House. But if the percentages hold true from Troop and Lindale, you're going to see probably about 117 to 125, 130, somewhere in there that are testing positive. And stop me if you have questions or
I have a
comments.
question.
Yes, sir.
So you said that these were not necessarily symptomatic that got the test. They just random people showed up and got the test, right? Okay, so for Lindale example, there was 382 people. You got 12.6% that tested positive. So could we say, and I don't even know, that the remaining 3,600 people in Lindale, if they were tested, you could extrapolate that there would be that many positives?
Well, statistically speaking,
I mean,
yeah, I'm not a statistician. Do you want to comment on that, Dr. Levine?
yeah, and I thought that would be
Yeah.
a question for him, but I mean,
I think that's an excellent observation, again, as we look at the numbers that we have. So there is a term we use in statistics called bias, okay? So when you look at a group of people who come to test who are symptomatic, for instance, we'll start there, and you say, well, about 30% of them turn positive. Well, that's because the base group that you're starting with, you have bias in there because they are more likely to be positive, okay? So then if you take a group who shows up to sort of random testing locations, the people who present, who self-present, have what we call self-selection bias. There are reasons why they decide on a particular day to go there because of the availability of the test. It is very possible that that overestimates the positivity in the entire community of 100,000, 200,000, or whatever, that number, that positivity rate is probably higher. Now, that's a good thing, right? Because it says, well, maybe not so many people are infected. In the case of this virus, it's a little bit of a bad thing, right? Because we're trying to get to herd immunity safely, meaning that the only way to stop the spread of the virus, period, is for more people to have been infected, either because of a vaccine that arbitrarily infects them in a way that they can build resistance, or by sheer, infection. And that even assumes that we know enough about the virus that the immunity that we build up is long-lasting. So it is an extremely good observation to recognize that this percent rate here may overestimate really what is the real positivity rate in the entire community.
That's a much better answer than I would have been able to give. And one other thing that underscores what Dr. Levine just mentioned is a number of the individuals that tested positive here, when we get the results back from the positivity numbers from any testing site, it'll have the addresses on them. We've noticed that in these testing sites, families are going together, and that there's a large number of families that are listed. So it may be perhaps that somebody in the family exhibited some mild symptoms, and everybody in the family decided, hey, let's go down and get tested because Johnny here has been sick a little bit. And so all members of the family show up, and they all get tested. And that shows up in the positivity rate. Yeah, those folks are more likely to have contracted it from their family member living in close quarters than you're talking about generally speaking in the community. Is that a correct observation? All right. And I recall even I think on the Lindale one, there was one where it was like seven people at the same location, same residence that had tested positive, and another one that was 4 or 5. So there were a number of big groups of family members that came together to get tested, which you would anticipate would have increased that positivity rate because they're living in close quarters and maybe one of them had it initially. Good question. Good observation. Any other questions about this? Okay, this is just a graphical example of what we just saw. If you don't like charts, you can see the graph of what we just indicated. Then I want to show you some numbers that Marshall Brooks put together, and I appreciate so much him tracking these numbers. He actually has put together a big spreadsheet to track on a daily basis a number of different counties that are close in our population. And I'll show you the populations here in a minute in a subsequent slide, but just so you know, these are the counties that are closest in population to us. Midland at the bottom is at 187,000. You see it at the top there, but it's the bottom of population. And then Webb County is 276,000. We're kind of right in the middle, listed at our population at 235,000. So these are the counties that are most closely similarly situated as far as population goes, and a lot of them share other unique characteristics to us as well, in that they are kind of outside urban areas for the most part, or kind of got their toe in both, just like we do. And you'll see the total numbers as of July 1st and July 18th, and see the growth, and then you'll see the active cases, and as was mentioned earlier, active is kind of hard to measure on a day-to-day basis because that is not the primary focus initially when the numbers come back. The focus of Net Health is to figure out how to trace those that are now newly known as active. Newly known as having gotten the virus and not necessarily who should roll off on the back end. So you see those numbers as well, and where we've gone here in Smith County from July 1st at 618 to a total of 1762 as of last July 18th. So it's just 3 days ago. Give you a minute to study that chart and see if you have any questions. I'll tell you that from a growth perspective, you can see we've just about tripled since July 1st in total cases. And Hays County and Brazos County, even though they were much higher than we were at the beginning of July, have done a better job constraining that growth and have not quite even doubled. They've kept it under a double factor. And that's something we want to watch as well. All right, any questions for me or observations from you about that particular chart? And you see the number of tests. I know folks are interested in that. A lot of this is just information we want to put out there so people can get a chance to look at it and divine for themselves any conclusion they want to reach based on the data. But you see the number of tests performed. This is a graphical representation of what you just saw. The orange is the number of tests done in each one of those counties. The blue is the number of active cases, and the yellow is the number of total cases that you see. So what is happening here is certainly not uncommon to what is happening in some of our sister counties, and in fact seems to be more under control, not to say that it's under control, but more under control than some of the other counties. but for some of those trends I just talked about in Brazos and McLennan County, or in Hayes County here in the last couple of weeks. Then I want you to want you to see the number of those percent testing positive as a percent of population. We've talked about as a percent of those being tested. Don't confuse the two if you're looking at these numbers. So this is as a percent of population, and you see where we sit as a percent of population. We're actually, of our sister counties that are close in population here, we're one of the lowest, us in Midland County, as a percent of population based on the data that we know. You see Jefferson County and Hayes County are at the top with just under 2% of their population known to have tested positive. Questions about this or comments? All right, now this is the positivity rate of those tested. We just showed you in the prior graph as a percent of population, but we want to compare as a percent of those tested. Since we knew the total number tested, then we wanted to give you a percent, and you see that our percent is sitting right at about 13.68% of those tested have tested positive, whereas in Webb County, the largest one here, is nearly double that. Most are in the range that we're in, as you can see, somewhere between just under 14% where we are up to about 18%. So right in that 14 to 18% range of those being tested in our sister counties are being tested positive. Questions or comments about this? All right, some data conclusions just from me. Again, these are my conclusions to you that I just want to reemphasize to the community. Family and social spread continues to be the primary ways that the virus is spreading. To emphasize the age group again, the ages 21 to 30 continues to be the largest population of new COVID-19 cases. Hospital capacity continues to be a factor that we watch closely. And I will add to this that the reason why this is really important is not physical space, but it is personnel. ICU nurses and respiratory therapists are what I would say would be the bottlenecks if we got to a point where we had a whole lot of COVID-19 cases in the hospital. We're going to run out of personnel before we run out of space, would be the best way to say it. So we're watching those capacity issues and talking to the hospitals, mainly in terms of personnel needs, and they're aware of that and they're working on that. We trust and appreciate the preparedness that they've undertaken and the measures they've taken to prepare for additional cases. And both of those major institutions here in Smith County are doing a fabulous job, and we applaud their efforts. You see the bullet point on the percent increase from 5% in about June to about 13 to 50% in July. And then I just want to reemphasize the best ways to curtail the spread of COVID-19. Again, social distancing, wearing your mask if you can't social distance, avoiding large gatherings for long periods of time, and washing your hands frequently. And I'm going to add to this before we post it on the website two other suggested measures, which really are the more important ones as well, and that is stay home if you're sick, which is what George Roberts said earlier. And then I've been saying from the beginning, treat everyone as though they have COVID, but I think I want to change that and say treat everyone as though you have COVID, because that's really one of those things that may inform your behavior to, as we said, respect and love your neighbor in a way that you do not want to pass it on. We've seen a lot of statistics here that would indicate there's a lot of us asymptomatic, whatever the percent is. It doesn't matter to a large degree what that percent is, but we know that there's a lot that are asymptomatic that don't know they have it if they haven't been tested. And so we need to treat each other as though we have COVID-19. That way we do not pass it on to somebody that may be in that vulnerable population, that 50 and above, that 55 and above range with comorbidities. Those are the folks we need to be really, really, really concerned about getting COVID-19. So that's the end of my presentation. Again, I just wanted to add to some of that. Questions or comments for me?
I have one, I hope, last question for Dr. Levine about herd immunity. And you touched on it a while ago. So is the purpose is to get everybody eventually exposed to this? what does that mean once that happens? Is it if you've had it once, you'll never get it again? Or is it just a slower process? Or explain that to me,
We
please.
don't understand right now, to your last point, if you've had it once, that you would never get it again.
Do we know anybody that has?
There are some reports of cases of reinfection where people have had it early on, were not symptomatic, and then were exposed again, reinfected by a PCR test, and got sick. So what we do know is in a handful of cases thus far, there are people where that initial immunity may not offer them protection. We don't know why. We don't know all the circumstances for large numbers, what that means. And it does raise some questions about the whole issue of, can we get an effective vaccine? Now, understand that for none of these things is it foolproof. Probably the only example where we've been successful with anything like that, and not to mix vegetables here or fruits, was smallpox, essentially. You know, that's why we were able to eradicate smallpox from the world, because we could very effectively induce an immunity that kept people from getting it again long enough that there is no longer any spread of the smallpox, right? The virus doesn't live out there. It's not like the virus is still living out there and it's because we've all, because we haven't vaccinated for smallpox in a long time. Smallpox, except for some scientific vaults around the world, has been eradicated from the earth, okay? So we don't know if we can do that with this virus. For other viruses, we haven't been able to do that. That's why we get a flu vaccine every year, because it doesn't give long-lasting immunity. To your question about herd immunity, what we do know is that these viruses that are eager to infect humans, okay, the more humans have any immunity whatsoever, the less successful that virus is of infecting humans. And finally, it gives up, okay? The epidemic goes to sleep, all right? It's kind of like measles, right? If we have people who haven't been vaccinated and measles that hasn't been eradicated from the earth sneaks in and gets into those people who haven't been vaccinated, it finds a perfect opportunity to take a small little ember and turn it into a big fire. What is the rate of herd immunity that we need? It's different for different viruses. In general, better than 50% herd immunity. Optimally, probably in the 60 to 70% range for most viruses. Hopefully that answers your question.
And I do have one follow-up question, Dr. Levine. Thank you again for everything you do. You know, we were all hopeful, and some of my closest friends or physicians that I have the greatest deal of respect for, we were all hoping that this virus would follow other trends for midsummer, the heat, and that ended up not even seeming to affect it at all. If anything, it seemed to be. Then we had the large gathering and marches with the young age group that obviously, you know, whether it's the bars they went to or the marches they went to, somehow those numbers spiked. But is there any indication that the lighting and the heat just really hasn't been effective on this to any degree from the scientific end?
So of the many different pandemics we've had over the last couple of centuries, they seem to respond a little bit differently. At this point, this virus does not seem to respond in that way, that different temperature and humidity ranges in a massive environment in a geographic region seem to have any real particular effect. It does raise some interesting questions about indoor environments, which is a completely separate issue. But in terms of seasonal changes, it doesn't seem to be a virus that works that way. This one seems to be just these little hills, a little bit of valley, hill, a little bit of valley. This thing is going to smolder until we get to herd immunity or a vaccine.
The only other question, I promise I'll be quiet after that, was totally selfish on my behalf. As George knows, I'd gone to Israel, got back, we're sick. My wife actually got sick. At the time, we had no test because it was a brand new virus. Last week in February, in fact, none had shown up here in Smith County, but tested positive for the flu. And I've had conflicting things that I should go get an immunity test because there's other people like myself that have traveled overseas, came back and were tested for the flu and had it or thought they had the flu. Are there reports of people having the flu and COVID? Because I've heard yes and I've heard no. Do you know in that? If you could have both at the same time?
If you can have both at the same time. It's a little unusual to be infected with two viruses at the same time. I have not seen case reports or heard much about that, to be honest with
It'd be a very small percentage. If I get it back and I do it, I'll let you know if mine.
Viruses don't like to share humans.
Okay,
right?
good for them.
They tend to. Now, it's different for having super infections with bacteria and fungi, right?
Mm-hmm.
But viruses don't typically like to share with other viruses. They latch on, they make someone sick, and they say, you know, we've taken over the machinery of the body, you go find somebody else, basically.
Right. Well, that's good news. Well, I'll let you know how mine comes back.
Dr. Levine, is some of the people testing positive that show no symptoms, do they eventually show symptoms, or is there some people that it just don't affect?
There are some people who, a very good question. So there are some people who show no symptoms. It's interesting, you know, because I'm honing in on the word that you say when you said, well, they just don't have any effect. The reality is, by the time we show symptoms, often there is an effect in our body, right? But you have to get it to a level where you show symptoms from it. And symptoms are a bit of a late indicator. When you get fever, you have a lot of cough or phlegm production, it already means that at a cellular level there's some damage going on. For most viruses, the common cold, for instance, that damage is short-lived, the body repairs itself, and you're good to go. What we are seeing from this virus is that there are some underlying problems, potentially, that are being left behind. Now, whether that is occurring, because studies really haven't been done yet, in people who never have any symptoms, we don't know at this point. I think that's going to be work to be done later. You know, right now, we're just very focused on this issue of keeping people from getting sick and treating the people who do get sick.
Well, I guess my question is there could be some people just they're immune to it, or is that a possibility?
Well, there are some people who don't get very symptomatic and who don't really suffer any injury from that, and that does seem to be the vast majority of people that we know. I mean, even in the positivity rate, most of these people are not getting symptoms, and they're not necessarily going to the hospital. What we don't know is, did the virus leave a little mark behind that we could say is problematic for them later on? Those studies really haven't been done.
Thank you so much.
Man, those are great questions. A lot of good discussion. Thanks again to Dr. Levine and George Roberts for their work, their efforts, and their time here this morning. We appreciate that so much. No actions needed on item number 1. It's really a community item to make sure that we communicate out to the community what we're seeing in statistics and data and information so they can make good choices. Item number 2 on our agenda